I'm a primary care pediatrician, but I just happen to have access to a lot of really smart people that know what they're doing. So over the last couple of years since I came back to Children's, I've just kind of educated myself, and I keep asking questions. In fact, was on the phone this morning with a final question with our G-tube expert at Children's, Jenny Gibis. Some of you may know her well, our advanced practice nurse. And finally, at the end of the conversation, she looked at me and she goes, "Honey, just have them call me. If they've got questions, just have them call me." So I have access to people. So clearly, not an expert in the field. But I really want most of you to feel comfortable with G-tubes and trachs, at least to be able to identify them and have kind of an overview understanding of them. So that's what the purpose of this talk is. Both in G-tubes and in trachs. We won't go directly through these G-tubes or through the goals and objectives right here, but basically it's just that. Understand the type, understand the indication, understand why the child's got it, and then how to treat the common complications that arise with these G-tubes and trachs. So why are we interested? As Mark said earlier, increasingly we have more and more kids in our practice who are classified as having special health care needs. And of course that can mean many different things. This first definition that you see here, there are many definitions by the way, is one that's used quite often. And basically it just says that these are kids who require health care services more than your average kid. Well, that could be asthma. And some of our kids are very chronic with asthma and have a lot of medical needs. But it also could mean kids who are technology dependent and even more severely affected. So 50% of these kids actually have a disability that impacts their daily living. And then a much smaller proportion of these kids, and this is just an estimate here from one source, are technology dependent. And so then our next question is, well, dependent on what? What kind of technology? And clearly, respiratory support is actually the most common type of technology dependence. So even just a child who is discharged from the NICU on supplemental oxygen is technology dependent. Some of our kids have tracheostomies, which we'll talk about, and then some of our kids are ventilator dependent. Others need nutritional support, like G-tubes. In G-tubes, sometimes if it's short-term, sometimes jejunostomy tubes, which we're not going to go into that today. That's a whole other talk. And then venous catheters. So when would we need to do direct enteral feeding? Basically, the lowdown on this is that you need to, when the gut can be fed, but they can't take food by mouth, that's when you go forth with enteral feeding. So most of the kids that I see in complex care and many that I see in the Children's Health Center as a general pediatrician have oral motor dysfunction. So they have neurological disorders. Many of them had a noxic injury at birth or thereafter, and they're at risk for aspiration. So it's just not safe to feed them by mouth. And otherwise, sometimes kids have congenital anomalies of the GI tract or craniofacial anomalies. Some kids have failure to thrive or have severe feeding disorders that prevent them from getting adequate nutrition by mouth, or systemic illnesses. Even some of our kids on chemotherapy who can't maintain their nutrition with oral feeds will move forward to enteral feeding. So NG tubes, I'm going to just kind of brush over this pretty quickly. I don't deal with NG tubes that often because most of the kids that I end up seeing have moved past this or really never had this for very long to begin with. This is for short-term feeding. So this is if we think that the reason why the child needs enteral feeding is only going to be there for a few months because there are risks of this long-term. So sinusitis, mucosal irritation, dislodgement, obstruction of the tube. And in fact, that's actually, the dislodgement, losing the tube, is the most common reason why parents will seek medical attention when their child has an NG tube. You can pass these in your office. If the parents feel comfortable, oftentimes they do it themselves. That's what I've been so amazed by over the last couple years in this current position that I have is these parents are good. They're really, really good, and they know what they're talking about, and they continue to educate me all the time. So if they lose it or it obstructs, oftentimes they pass it. If it's a new tube, then sometimes they don't feel comfortable. They may call you or they may show up in your office. So here we've talked a little bit about like how to measure how long the NG tube should be, and then confirming placement as well. So we'll move forward to G-tubes. So this is a direct connection between the stomach and the surface of the skin. There are many different ways that they can be inserted either through a percutaneous endoscopic approach or a laparoscopic approach, or sometimes an open surgical technique if the child is getting a Nissen or another surgical procedure simultaneously, or if a PEG placement hasn't worked or is not indicated. The PEG was developed in 1980, and it's the most common form of gastrostomy access. And there's a couple different ways that these can be placed, but essentially it's an endoscope that goes down, it highlights, and it either can be a push or a pull technique. So when a kid comes into your office and they have a G-tube, the first thing that I like to do is, if they're in a gown, you pull back the gown. If they're in a onesie, you undo the onesie, and you look and you first just kind of try to figure out, like, what is this, And it happened yesterday in clinic. A lot of times I don't know, but sometimes I do. So you pull it back and you look at it, and the first thing you're going to notice is it's either got a tail on it or it doesn't. So there are long tubes, and then there are skin-level tubes, and those are the ones that people refer to as the button. When they talk about their button, that's what they're talking about, these skin-level tubes. Plus and minuses, I'm not going to go into really the reasons behind one versus the other in great detail, because that decision is often made by the GI docs and the surgeons long before they ever arrive to me. But the most common long tubes are the PEG tube and the MIC. And then the skin level is the MIC-key, and it's called, sometimes people say Mickey, it's called that because it actually has a key where the feeding apparatus will click onto the button that's at the skin level. And then the barred button, which I'll admit I've never seen a barred button. We don't use them I don't think we use them much at Children's at all, but we use the MIC-key quite a bit. So this is just a little visual on another way to kind of look at tubes, which is the tip of the tube, when you're trying to kind of differentiate and figure out what kind of tube you've got. So either the tube has one of two things on the other side that's keeping it in place. It's either got a balloon, which is filled up with either water or saline, usually between 3 and 5 cc's, and there's a little port on the side that you can withdraw the balloon, withdraw the water, and then push it back in again. Or it's got a mushroom bumper tip on the other side, which is like a piece of foam encased in usually a little bit of PVC or plastic type material. The PEG has the mushroom-like foam type thing, not the button. So I'm going to give you a case, and this is actually something I think you could see in your office. So this is an 18-month-old who had an anoxic injury at birth and had a PEG placement about a year ago, and now is coming in for her well visit. And mom has been told by the GI doc that she needs a tube change, but that she's going to have to undergo anesthesia. And mom's pretty upset because the child's had multiple procedures in the past and had been under anesthesia before, and she wants to know what your thoughts. So, doc, what do you think? What should I do? Does she need sedation? So a couple of questions that arise pertaining to this case. Number one is, does the tube need to be changed under anesthesia? 2, how long can that initial feeding tube be in place? And then what are her options for replacement tubes? So changing a tube. So if this tube is like that PEG that I showed you that has that mushroom bolster side on it, it can be removed either by sedation or by traction at the bedside. And if you, as I did before this presentation, go on YouTube for some, which I'll get to at the end, they actually show this as well. It really is, put your hand there and you pull it at the bedside. I've never done that. And if you talk to different practitioners, they think differently about this, because sometimes that bolster will come with the tube through the skin. Sometimes it will break and then it has to be passed, and there is a potential risk for obstruction that way. It's much, much easier if the initial tube has a balloon tip, because then you insert your syringe and you just pull out the water that's in the balloon, and then it literally slides right out. So how long can a tube stay in? So initial tubes at least need to be in place for a couple of months, especially those PEGs when they're initially placed. And the rationale behind that is you want to keep that tract open. You want that tract to form. So the initial PEG can be in place for a year, and I've seen some kids who've had them in place much longer because they haven't lost their integrity, so they stay. There is a Y adapter. I don't know if you guys have had the opportunity to write nursing orders for some of these kids that have PEGs if they come across your desk, but they'll ask for Y adapters. You'll have to sign off on the Y adapters. And the first couple times I did that, I was like, I don't know what this is. They need it for their feeds. Obviously, I'm just going to sign. And it's necessary. These little Y adapters, they fit into the end of the tube, and essentially they're just the port for medication administration and for the feeding. So those have to be changed out because they look cruddy after a while. They kind of develop a yellow tinge to them, and then sometimes they can get obstructed, and sometimes they just break down, or the little cap doesn't pop on and off. So if the tube accidentally becomes dislodged within 4 weeks of placement, that's an immediate call to the person who placed it. Because there have been issues associated with that, and you want to make sure that when it's placed back appropriately and it actually enters the stomach. So most often that initial tube is replaced by a low-profile button. Parents really like the buttons, and they said, like in our institution, it's often a Mickey. And those Mickeys, again, they have the balloon that you fill up with saline or water. Those then, after that, need to be replaced about every 3 months. And parents do that at home. They won't come to you for that. They'll do that at home. You can just ask them, how often do you change it? Any problems? No. And they just move on. The barred buttons can be changed less frequently, even yearly. Sometimes a balloon-type long tube is used, and it's kind of parent preference and sometimes provider preference as well. The GI guys will sometimes indicate a longer tube versus a skin-level tube. So this is a table from a really good contemporary pediatrics article that basically focused on G-tubes and Broviacs and venous catheters, which I didn't go into today, that talks about different complications and then therapies surrounding G-tubes. So I'll go through, I'll leave this, we're not going to go line by line, but I'm going to highlight a few things. The first is if it becomes dislodged again and it's early on in the process, and I would even argue that you could stretch this to more than 4 weeks just for a little bit of certainty there, that initially you need to call the service that placed it. And if it's after that, then you can replace it. If it's obstructed, and again, this is less of an issue now that we've got these disposable buttons, because if it's not the initial tube and it's a replacement tube and it becomes obstructed, really what people usually do is they just replace it. But you can try to insert a little bit of carbonated water into it. Our advanced practice nurse has used a combination of meat tenderizer and pineapple juice. If it's a food-related plug, if it's a medication-related plug, a meat tenderizer isn't going to help. If there's leakage, which the leakage and the granulation I want to spend a little bit more time on because I really think that's what you're going to see in your practice. So, if a child comes in and it's leaking, the first thing you want to know, you're going to want to look at the quality of what's coming out of it, clearly, which we'll get into in a minute. But you want to check the appliance in the balloon and make sure that, like how much water do you usually put in the balloon? Oh, I usually put about 3 cc's. Well, let's check and make sure. When did you last check it? Sometimes it just gets loose and there's more play and then it leaks a little bit more. You also have to look and make sure that ask and make sure that the child isn't constipated or that you're worried about an obstruction more distally. Then also, illness can also do this too. Illness can cause a tube to leak quite a bit, which is not something he mentions here in the table, but it's something that I see, and I don't think anyone completely understands it. I know when kids get upper respiratory infections, then oftentimes their gastric motility is affected, and then they get a little bit more kind of sometimes cruddy looking discharge from their tube as well, but it leaks more at the site. You can replace it with a smaller caliber tube. If it's a chronic leaking issue, you can replace it with a smaller caliber tube and then let it sit for a week and then go back and try to insert the larger tube, and then the stoma will have closed up a little bit and you'll be able to hopefully have a little bit of a tighter seal. For skin protection, this was actually something that I was asking. I wasn't satisfied with this because you want more information, then call the stoma specialist. So one thing that Jenny Gibas, our advanced practice nurse at Children's, uses quite a bit, and I haven't, I thought it's a great idea, is if the child, if the area is leaking chronically and you're working on it, you think you kind of have a reason, but you know what, sometimes they just kind of ooze, then you can use gauze. The gauze is going to get wet, and then it's going to have more maceration and irritation at the site. Or you can actually, what Jenny does is she uses an unscented sanitary napkins. And she has them, cut them in small pieces, and she places them around that. And she's like, women wouldn't use them if they aren't absorbent. And it's true. And so it absorbs all of that leakage there, and it really helps. And they're less expensive than other stuff, too. Granulation tissue is the other big issue that you'll get called about, and the nurse at school will call you or the home nurse will call you and say, I just don't know, it looks really, really, really red. And so then you have to kind of figure out, why is it red? Is it, like we'll talk about in a second, is it granulation tissue? Could it be infection? So the first thing to do when you see redness around a G-tube site is to really inspect it and see, does it look like a cellulitis? You know, if there is erythema and it's indurated and it's warm and the belly is tender and there's other stuff going on, you're going to be more worried for infection. If there's granulation tissue, so it looks pink and kind of shiny around the surface, then that's usually caused by friction of the tube, and it's granulation tissue. And you can actually treat that. You don't, we're always here, but you don't need us for that. You can actually treat that. You can treat it with silver nitrate, just like you do the umbilical granulomas. And you can also treat it with either hydrocortisone or even a stronger steroid cream as well. And that usually will take care of it. I have had a couple of kids come in that even I wasn't certain that was granulation tissue, and sure enough it wasn't. It was actually gastric mucosa. So if it looks beefy or red and kind of more muscular, then it's probably not granulation tissue, and that's probably something you need to talk to the GI folks about too. So let's move quickly into tracheostomies. So essentially this is just a little bit of terminology. I know we just switched gears kind of fast. But so essentially, you know, the tracheotomy is the actual incision, the tracheostomy is the tube in place, and the stoma is the hole that's created there. So why do kids get tracheostomies? So if they have to have long-term ventilation, or if there's an obstruction that they're trying to bypass or relieve. Complications include obstruction of the actual tube, and then, you know, you're worried about the airway, unintended removal of the tube, infection, or granuloma at the stoma site. So the different types of tracheostomies, you can classify them based upon the material. So the most common in the past was a metal tracheostomy. Now more commonly and pretty much almost completely are either the plastic or the silicone types. And the two that we use at children's most often are the Shiley and the Bavona. So the Shiley is plastic. It's disposable, which we'll go into in a minute because I learned something about this really recently. And when I say replaced every 2 to 4 weeks, they're actually, all the trachs are changed weekly, usually unless there's another indication. But this tube is actually good for 2 to 4 weeks, so it can be cleaned, placed aside for a week, and then reused the next week, so that you don't have to have 4 trachs for a month. And the Shiley also can be cuffed or uncuffed. Now the silicone is more expensive. The Bavona is more expensive. It's actually got a little metal in it, which is important if your child's going to go to radiology for an MRI. It can be cleaned and reused multiple times. And again, it has to be, we'll go into a minute, it has to be cleaned a little differently. And it can be cuffed or uncuffed. So when you talk about 2.5, 3, 3.5, they're talking about the size, the inside diameter of the tube. There's also a measurement of the length of the tube. Some are single and some are double cannula. Typically, most of the smaller ones are all single cannula, and then some of the older children have double cannula. So the inner cannula can be pulled out, and even multiple times a day can be changed or cleaned, and then the outer one stays in and then is changed usually weekly. So routine trach care, this is usually done about twice a day, and the families will tell you we did trach care this morning and the secretions were clear. Usually there's different ways to do it. They can dip a Q-tip in peroxide and sterile water or sterile water alone and basically clean the area around the stoma. Changing the ties. So the ties essentially, if you guys have seen them, you know, your trach sits here and then there are ties that come around the neck, and they can get very wet, especially if a child is drooling often. So those get changed at least, usually at least daily, sometimes twice a day. And that's a 2-person procedure because you want to make sure that you maintain that airway, especially a kid who's really active is going to pull that thing out. So if you're taking off the ties, you've got to have 2 people there. So the other thing that's an issue around trach care is humidification. And oftentimes an additional source of humidity is needed. So a nose will be placed over the trach, and that actually kind of filters and humidifies the air a bit. And then you can apply saline, and the parents will do this directly inside the trach to loosen up secretions and allow them to be suctioned. Chest BT is a part of trach care. Suctioning. I say here 2 to 3 times a day. It's really as often as needed. I mean, some kids, when they're sick, they get suctioned all the time. And I've said here bulb or catheter. It's usually catheter. It's usually a long catheter that they place down. Changing the tube is usually done weekly, but can vary. So this is what I was talking about, the Shiley and the Bavona. So the Shiley has a life of about a month or so, and it can be cleaned and then rinsed in sterile saline, allowed to air dry. You put the other one in now. You've taken that one out. It sits for a week, and then you can change it back again, which was something I didn't know. Some insurance companies will pay for a clean trach every week, and if that's the case, that's great. Some won't, and so therefore they're forced into cleaning. And I've listed different cleaning solutions that you can use. Really, if you ask 5 people who deal with trachs, they'll tell you 5 different things. And so I usually say I go based on what the package insert says about the trach. And then the Bavona trachs can last 2 to 3 months, and those you clean with soap and water, and you store away, and then you sterilize again with boiling water before you put them back in again. So complications. So you can get a trach plug, so you get a mucus plug down in your trach, and then if this is the child's airway, it's a big deal. So you suction, and if you can't get it out, then you replace the trach. And of course, if the child's decompensating, you have any concerns, then obviously this kid needs more emergent care. Parents deal with this often, and I have a couple parents that'll call me, oh yeah, I plugged 3 times last week. And to me that would be a big deal, but to them they just go right on. So bleeding, it can be caused by vigorous suctioning or suctioning too far. It's pretty normal to have kind of pink streaked mucus, but if there's a significant amount of bleeding, that's an issue. Infection, and I think this is sometimes hard to tell, like when does a child have a tracheitis and when do they not. And I think that oftentimes they get put on antibiotics when there's secretions until you really find out if indeed it's normal kind of flora growing down there, if it's something else. But it certainly puts them at greater risk for infection. So doing a trach culture is what's needed if they have discolored secretions. And if the trach tube comes out, then oftentimes it's obviously it's always an emergent situation. If the family can get it right back in, great. If they can't get it back in, sometimes the child can breathe through the stoma, sometimes not. That's an ER issue, clearly. You always want to have a backup of the next smaller size, and that's one thing I think it's important to kind of make sure the parents feel comfortable with, that, okay, you've got your 3.5, and what's your backup size? And they'll say 3.0, great. And the parents are obviously CPR certified. This was fascinating to me. I always kind of wondered why some kids were able to speak around a trach and other kids wouldn't. Well, it obviously matters on how much airflow they get around and over the cords. So it depends upon the fit of the tube and also how healthy are their vocal cords. So one thing that a lot of my kids have, especially if they're kind of moving towards decannulation, is they'll have a passy-mur valve. So it's a device that enables them to make speech. So it's a one-way valve, and it literally caps and just sits over their trach. So air can pass in, but it can't escape. So then that air has to pass up and over the vocal cords. It's harder for these kids, and some kids tolerate it for 5 minutes a day, and some kids tolerate it for half a day. So the ENT and sometimes the pulmonologist will work very closely with you as a primary care pediatrician, kind of managing these children as they're trying to move forward and get them onto the passy-mur. Other kids will actually just plug their trach to say something and then move right along. Or a fenestrated trach, which happens in some of our kids too. There actually are holes in the trach and allows airflow up and over. So decannulation is the actual removal of the trach tube. So basically the only reason that this would come out is if whatever reason that you had for having the trach in the first place is now gone, resolved, you've moved past that. So sometimes the kids are stable enough, I've never seen this, that they can just remove the tube. Most commonly there's incremental time where you plug the trach or use the passy-mur as a transition, and then increasing the time that the trach is plugged. Oftentimes a sleep study is necessary just to confirm that everything is going as should be. Sometimes these kids need surgical reconstruction of their airway too. So my second case here is a 2-year-old boy who had a trach placed recently, and mom calls your office because she has questions regarding trach care. She's still kind of in that, not quite sure because she's just now home, and she ran out of that special gauze that they use, the kind that's cut up the center and goes around. So can I just cut the gauze at home and place it around the trach? No. You can't. And the reason is, again, something I learned recently, is that when you cut the gauze, it releases little fibers that can actually get inside the trach. So the answer to that is no, don't cut the gauze. Let's get the special gauze. Most of the time this is called, it's called an IV sponge. Essentially, it's just pre-cut with a notch to kind of go up and around the tracheostomy. So these are some helpful websites which I would encourage you guys to look at, and you can also give these out to parents too. I searched all around them. I just felt like they had a lot of really good information, the tracheostomy.com and the kidswithtubes.org. And then YouTube, again, it's one of those things where it's YouTube, right? But there are some interesting home shot videos of how parents change tubes and things like that too. That's kind of, I think, informative to us as physicians and kind of understanding what these families are dealing with and how much they're able to do at home. And I think it's helpful for other parents to kind of see that there are other parents out there going through the same thing.